Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by Revel plus NovuHealth. Our presenters today are Amy Feeley-Austin, Director of Quality with AlohaCare, and Jihan Golden, Senior Healthcare Engagement Strategist at Revel plus NovuHealth. And they will be presenting the webinar, Driving Stronger Member Experiences Through Proven Engagement Strategies with AlohaCare. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. Please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website, and just look to the top of the homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking on the Q&A icon at the bottom of your Zoom window and by typing in your question. And all questions will be answered at the end of the presentation. Now, I'd like to pass it over to Amy and Jihan.
Hello, my name is Amy Feeley. I'm the Director of Quality at AlohaCare. So first, a little bit about our plan. AlohaCare is a community-led nonprofit plan. It is located out of Honolulu, Hawaii. We are a plan that was designed, conceived of, and raised by community health centers. At the inception of our Medicaid integration here in the state about 25 years ago, which means that today we continue to be really driven by the needs of of Hawaii's community health centers. All of our board members are the executives at our state's community health centers, and it's really our connection to the community. So as a plan, our mission is to support individual wellness, to promote community access to quality care in close collaboration with those 14 community health centers and others who share our commitment. So that means any other organization, community organization, or provider who shares our values. About our islands. So, just if you haven't been here, Hawaii is kind of everybody's dream, right? So this is vacation paradise. It's a beautiful place. It really is. The first thing that strikes you when you do travel here is just how far away from the mainland it is. So the closest mainland is California. And you'll notice if you're flying out of LAX or another, airport in California, the distance that you're traveling to get to Honolulu is about the same distance and the same amount of time as it takes to get from Boston to California, right? So it's over 2,000 miles away. We're very, very far out into the Pacific Ocean. And this causes a lot of issues with healthcare delivery that we'll talk about in just a minute. So important to know that there are 6 main inhabited islands. Where the star is there, that's Oahu. Honolulu, that's where I am right now. That's where I live. And that is where our plan's based out of, although we serve folks on all 6 of the inhabited islands or the main inhabited islands. And it's really important to know that we do not have a ferry. A lot of folks have this sort of conception of Hawaii that we can just kind of like swim or boat back and forth. We cannot. And so Oahu is not the largest geographically, but about one of the 1.4 million people in the state. So the vast majority of people in the state are living right here in Oahu. Most of us around that south facing coastline. And the remainder of those individuals are living across those other 6 islands, which means that some of them are quite rural, very rural. We are the 50th state, and it's also important to know that we have the highest percentage of Asian Americans and multiracial Americans and the lowest percentage of white Americans of any state. So we are the only state in the US where the majority of people are Asian Americans, and the only state where, therefore, there is a minority of white Americans. So why is this important, right? Apart from just being really interesting and making everybody insanely jealous, really that remoteness, that isolation, it causes a lot of issues, both in terms of, the things that we have to send back to the mainland, like tests, the cost of travel, the cost of things that get shipped in. Everything gets shipped in unless it's grown here, so everything costs more. A lot of people have heard about, the price of milk and bread, like those sort of basic staples in Hawaii. A gallon of milk can often cost $6 or $7. Because this is a highly desirable place to live, there's a lot of people that have second homes here that are really wealthy people from mainland or who have invested in homes that they rent out as illegal vacation rentals. And so the housing market is really just insane. It's really, really expensive. And so this puts a huge financial pressure, a huge burden on our population. So, the folks that we see in another city that are those low income folks, here it's just kind of exasperated by this lack of housing, super expensive housing where a small 2-bedroom apartment could cost, $2,000, $3,000 a month for rent. Also, that main source of inter-island travel is air. A lot of the specialty care is only located here in Oahu, which means that neighbor island members, of whom we have a lot, many of them really have that as a barrier. Like if they need to get, to a cardiology appointment, they may have to hop on a plane to come here, and that is a huge barrier for people in getting regular care. Also, we have significant cultural needs of our population, and they apply to a lot more of our population than other folks may be used to in the mainland. So just digging into that a little bit, as a dominantly Asian and Indigenous state, cultural competence, it's really not a trend or a buzzword. It's built into everything that we do. And I want to kind of preface this by saying, as I usually do when I'm talking about my sort of adopted state here, I am not from Hawaii. I am not Native Hawaiian. So I am still in the process of learning. I am not an expert in this. I don't consider myself an expert in the cultural nuances of the state of Hawaii, but I do care about our patients, our members, and I do try as hard as I can to make myself aware of the nuances. And so I'm going to share what I do know with you. So the language is really important. There are a lot of languages spoken here. The dominant non-English languages are not sort of the traditional Spanish. We have a lot of different unusual languages: Ilocano, Shukis, Marshallese, Tagalog. We really have, I would say, at least half of our members or more are speaking another language. So it's really important to translate information. We do use certain types of blended language as well. So people have probably heard of Pidgin. Pidgin is kind of like the casual parlance of local people that live here. And it's blended, right? So we use Japanese words and Chinese words. We use Hawaiian language like aloha and mahalo, and keiki, which means children, and kapuna, which means elders. And it's really important because if we send out information or we have calls being made to members that do not sound like this, they're not really well received. So it's really important for us to think about the way that we're communicating with our membership and that it seems relevant to them and it seems local, because they'll just turn it right off if it doesn't. Really important that Eastern and Indigenous medicine has to be a respected part of the holistic healing process. So we do know that history and context in the state of Hawaii have created somewhat of a distrust in Western healthcare delivery systems, and something that this is kind of where I like to take a break to tell a story. If you're a history buff like me, I encourage you to learn more about this. But the history of Hawaii, as the 50th state, this is not multiple generations, 7 generations ago. There are people who are living today that remember when this was not a state. And it has a history of colonization that really has caused a huge loss to the Native Hawaiian population. At the time that Hawaii was colonized, they guess that there was about a 90% loss of the native population, mostly due to disease. And that was brought in by people who were landing here because there was no exposure to those diseases. And so on the lower right corner there's a picture that I took when I was visiting Molokai, which is the neighbor island that I can see to right off of my porch here. I can see it, although it's difficult to get there. And on that island there is a 1.5 square mile peninsula on the north shore of that island. It is at the bottom of a 2,100-foot sea cliff. And I hiked it. It's really, really difficult for a healthy person to get up and down. You can go there now with special permission. But at the time, probably, late 1800s, early 1900s, that peninsula on the north side of this very remote island was where people were being essentially abandoned if they were ill and living in Oahu, in Honolulu, as a means of naturally imprisoning them. And so if people were discovered to have leprosy and they were living in the island of Oahu, they would be forcibly taken to that area and declared legally dead and left there to live out the remainder of their lives. And this is something that ended maybe 80 years ago. They're 75, 80 years ago. There are still a couple of people that are living there that have chosen not to leave. And it will eventually become a national park when they pass. But this is kind of the historical context, right, for a colonized state that used to be another country. And it's a very different place to live and a very different place to work. And so just before I move on, I just wanted to share this as kind of like to give a better picture of what that same island, Molokai, looks like today. On the top left there, you can see the downtown area. Right up the street from there, there is a 9-bed hospital. If you are pregnant and you are going to deliver a baby and you would like an epidural, even if you're a non-complicated birth, you have to come to Oahu because they don't have an anesthesiologist. So this is the degree to which there is a barrier to services on these islands. There are maybe 2 or 3 primary care doctors, and the majority of the island is really uninhabited. The flights, that plane there, that's another picture that I took of the plane, 9-seater plane that I was about to get on. There are 2 or 3 flights a day. They're very small flights. So a lot of the time when people do come from neighbor islands to Oahu, they have to time very carefully. Sometimes they have to stay over here if there's not another flight back to their island. And these are all things that make it really difficult for people to get care. So we have approximately 70,000 members right now. It has risen recently due to COVID. The majority of these folks live in Oahu, but we have a disproportionate share of neighbor island residents on our plan. We do have a lot of kids, a lot of pregnant moms. There are a significant amount of houseless individuals on our plan as a result of the very high homelessness rates here in the islands. Our unattributed members, so these are folks that are not actively seeing primary care, is usually hovering around half. And I'd really like to see that go down dramatically. We do struggle with quality, although we've been upward trending from 2015 to 2019. Obviously, this year kind of blew everything up, but generally speaking, we have been upward trending, but still a struggle, right? And we have a high unable to reach population. So folks that we have contact information for, that is not good. That is not allowing us to get in touch with them. And I think some of the barriers for them, low health literacy, language barriers, the effects of racism and generational trauma, some of which I already described. Also, we are home to a lot of people who have COFA, which is the Covenant of Free Association. So Micronesian population is very large. They're able to come here because of bombing that the United States did to the Micronesian islands. And there is a great deal of racism towards Micronesian individuals, as well as language barriers that we're trying to overcome in terms of getting these people to care. Lack of access. So that geography, it has a huge impact on people's access. A lot of the time when I look at rates of things, they're a lot lower on neighbor islands because they don't have easy access, so they just don't do it. Poor health. So really, this is kind of one of those tricks. Like if you look at most of the health indicators in aggregate, the state of Hawaii is usually deemed to be like the first or second healthiest state in the nation. But in our population, the health can be quite poor. There's very, very high rates of diabetes, cardiovascular disease, and so on. There's just a lot of barriers related to social determinants, the impact of extreme poverty, the cultural considerations. So really what I want to know as a quality director, my first pass before I can try to improve, different measures, I need to know, or I need to get members to understand their benefits and what type of care they need to get. And I need to know what gets this information read and what gets them to take an action. In terms of our own organizational challenges, we are a local plan. We have great relationships. We have great relationships with our providers, great relationships with the state, with a lot of organizations. We're well known for being a big reinvestor in our community. But we did become, I think, a bit complacent over time with just a slow, steady progress in quality. We have had lots of consecutive changes in quality leadership over time. And people have different philosophies, which means different strategies. So something gets tried, then it kind of gets scrapped. We do have we're small. We have a lot of different high need populations. And we're always trying to shoot for that national benchmark in a state where it's really difficult to meet the national benchmark for the reasons that I just mentioned. We have a very, very small Medicare program, less than 2,000. I think at times there has been less attention to our Medicare program than we should have given it. And so our stars had suffered during certain years. And then, our state does have a withhold model. It gets larger year over year, and it gets larger as those targets become harder to reach. So then COVID, it would be impossible at this point to have a presentation and not talk about the impact of COVID. We are the highest cost of living state in the US, as I mentioned before. We continue to be that. And we're a tourism economy. So closing down the entire state for months in order to address this really critical issue had a huge impact on people. We normally have the lowest unemployment in the US. Right now, we have the highest unemployment in the US, as far as I am aware. And so it, it really had a huge impact. There's a ton of people out of work. That huge jump you see there and that red line on the total monthly enrollment is coming. It's really being driven by unemployment, people that normally would have private insurance through their employer. We also have even more limited access inter-island. So imagine, not only now do you have to overcome the barrier of not having adequate flights or having to go on a flight to get to Oahu, but you also have to figure out how to address an inter-island quarantine. So we actually have an inter-island quarantine policy too. They've changed from sort of month to month as we've gone through this process. And often they have involved quarantining when you come from one island to another, with the exception of medical care and requiring special permission. So that's been really difficult for people, and it's caused us to face a lot of questions like, what is our responsibility as a plan to keeping people here versus sending them home and then coming back, right? Just really, really complicated stuff related to getting basic care to our members. So enrollment also has gone up while a lot of care has been deferred. And so this is driving our measures down. So for me, this is really kind of a turning point, right? We have greater withholds. That withhold is still there, even though we're going through what we're going through right now as a state and as a country. But it is a really clear-cut ROI, short-term ROI, to say, we have all of this money that's being withheld. If we can get people to care, we can get some of that money back. We also have a new state contract coming, so that really drives home the importance of being competitive. A lot of our competitors are national plans. They do benefit from resources, right, that are available to national plans. And I think this is really just a situation ultimately where a true public health crisis has exposed a lot of vulnerabilities that we didn't really realize were there. And it's changed the conversation about care delivery and how we can help people get their quality, the gaps in care met, and how we can improve our quality even when there's a bunch of stuff kind of bearing down on us. So we turned to Novu, knowing that they were an organization that could help us build out a program to try to get people engaged, to try to get them attributed, to try to get them to that badly needed care. And that we knew that we didn't have the time or the resources to ramp up quickly and deliver this kind of programming, and reached out to them to help us out. And I think there I will turn it over to Jihan so she can talk about what we've developed together.
Thank you, Amy. I'm Jihan Golden. I'm a senior healthcare engagement strategist here at NovuHealth, and I've had the privilege of partnering with Amy and AlohaCare. And Amy walked through, some of the challenges that are really unique to AlohaCare and really unique to Hawaii. But I imagine some of these really resonate across other Medicaid plans. So I'm going to walk through how we partnered with Amy and AlohaCare to execute a member engagement program that's in its really early stages. It launched in late September. But we're already seeing really what we'd expect to see because we're using some proven strategies in member engagement, including multi-channel engagement and outreach and incentives. At NovuHealth, we did just recently merge with Revel Health, which we're really excited about. We really do believe that we've cracked the code in optimizing member engagement and improving quality and member perception. We are not the experts in Medicaid and AlohaCare's membership, so it really does take a collaborative partnership, which we have in Amy in the plan. So I'm going to walk through the AlohaCare Wellness Rewards program. I'm going to highlight some best practices and go through some data and key learnings that we've had in executing programs like these in Medicaid. And I'll also walk through some tips in evolving a program over time. So to start, the framework of the program is really grounded in AlohaCare's objectives. Amy mentioned, the North Star really is improving quality. The state withhold is getting larger each year. Greater withhold does mean a more near-term ROI, and that competition from plans and the continued push in the benchmarks is a real challenge. So that's where we're focusing. The program also needs to help members overcome barriers. That's a really big key to improving quality. There's barriers in language, there's cultural barriers. Amy mentioned the access barriers that members have to sometimes get on a plane to see specialists or even get basic care. Health literacy is a real barrier to overcome. And we really have to make sure that we're educating members and that we're really clear in our asks and that we're proactively addressing member concerns when we're trying to get members to take health actions. We have to help members navigate the pandemic. That's an added barrier that COVID-19 has put into play. Members don't know when they should engage and get care. There's a lot of parents questioning if they should get their children immunized or if they should wait or if it's safe. And finally, as Amy mentioned, they really want to support their members to understand and use their benefits. And connecting with members and getting members to engage really can't just be a welcome kit and posting information on the website. You really have to meet members where they are. The consumer market has figured this out, and your members at the end of the day are consumers. They're groomed by companies like Amazon that have on-demand and tailored experience and are really kind of curating their messaging to individual consumers. And plans really need to look to that example to create relevant experience for members, because that's what members are coming to expect, and that's what it really takes to cut through. So these 4 objectives are going to be our North Star, and we're going to try to make sure as we execute this program that everything we do is really working to achieve those. With quality improvement, we need to prioritize measures that will deliver the most value. So we have to engage members to do the most important things first. And that means choosing high value activities for the program that really are going to align and ladder up to those business objectives. So the value can be rooted in ROI from a state withhold, as well as health outcomes and cost avoidance. With the AlohaCare Wellness Rewards, we've really focused on both. The state of Hawaii has 9 performance measures that they're tracking that are assigned specific weights. And the projected target is the 75th national percentile, which is why that national benchmark is important. The plans can earn 100% of the incentive measure value back from hitting that 75th percentile. But the good news is that if plans show meaningful improvement anywhere from 5% to 100%, they can earn some portions of that incentive value back. So that's very good news for AlohaCare. In addition to the 9 member measures that we are tracked by the state, we're also reviewed the historical performance of other measures AlohaCare was focused on. And we set 3 specific goals in 3 categories. First is improve. These are measures that we think we can improve within the near term of the measure year that are gonna have the most value. Progress, we'll set a goal on a measure if it might need a multi-year long-term improvement strategy, but there is benefit and incremental improvement within the measure year. And there's also measures that AlohaCare has done a lot of work to make progress in and has the performance that we want to make sure that we protect and it doesn't fall back. These goals are important at the measure level because this analysis really does play out in how we execute the program and how we prioritize activities for the member, and then how we ladder up those reward amounts. In the AlohaCare Wellness Program, we're focused on chronic conditions, both diabetes care and blood pressure control. We're focused on well child visits and children's preventative care, cervical cancer screening, chlamydia screening, as well as prenatal and postpartum care. Once we've selected and prioritized healthcare activities of focus, we're segmenting the eligible members for those activities based on their historical engagement. We want to set a program where all eligible members can engage, close activities, and earn rewards. But segmentation is a really important best practice because it really does laser focus finite resources on historically non-compliant members to drive the most efficient and effective gap closure. If AlohaCare has half of their members that are engaging and closing gaps, that's really not where they need to focus. They need to spend the marketing efforts to drive those members who aren't closing gaps on their own and help overcome barriers in that group. So that's where we're focused. We've employed an opt-in strategy where in Medicaid, you need a pretty aggressive marketing campaign to direct members to get them to take health actions. And so we ask them to join the program and then report the healthcare activities that they complete to earn rewards, as opposed to simply rewarding members for closing any open care gap, because that really primarily just subsidizes members who are already compliant on their own, and it really isn't going to move the needle in quality. So focusing the segmented outreach efforts on targeted members who are historically not engaging, we ask them to opt in, and that's really what shows that incremental behavior change. That allows the program to be measured and demonstrate value. It also helps with attribution, as AlohaCare has other programs that they're using to drive measure performance. Having the member opt in can really show where this program is adding value for AlohaCare. And then Amy mentioned her focus obviously is on overcoming barriers, and we want to make sure that the information gets read. One of the best ways to garner attention is with incentives, and incorporating incentives is the value exchange, right? It's the value prop of the program, and it's what kind of earns the right or piques the interest of members to talk to them about other things in their health. The type of incentives does matter. We've done a lot of testing in this space with rewards, and gift cards, hands down, perform the best. They're simple to communicate. They're operationally a lower lift, and they become the tangible value prop of the program that's recognizable. Other reward types are merchandise, which can provide good performance. They also can limit member choice and be sometimes costly to store and ship. Another is the point system, where members can accrue points that they can redeem later in catalogs. We found this doesn't work best in healthcare environments because it can add barriers and be confusing for members, as well as discounts. So we've really recommended gift cards. And a key best practice for gift cards is choice. Not all members are the same. They don't have the same needs or preferences or even access to the same retailers. So if you're offering a $25 gift card to complete an activity at a retailer that a member knows is not in their neighborhood, town, or city, the value prop really isn't there. So we need to have something for everyone. A perfect example in AlohaCare is some of their members live where they can only get shipments from Amazon because there are no other retailers. We also do recognize that a lot of states have gift card requirements that restrict alcohol, firearm, and tobacco. So that's a key consideration. Walmart and Visa offer some good special ATF cards. Another way to meet this requirement is to add retailers that don't sell ATF goods. So in addition to providing this choice, we like to curate cards where members can use them for basic needs. So we always want to make sure in a program that there's a card for food support or transportation or home goods. And we do hear from members in our live call center calls that this is a big motivation. Members are talking about how they're struggling and every little bit helps, and that the gift card helps. The second key to rewards is really an optimal reward amount strategy. We find that that the reward amount that you put on each measure isn't always the best performance at the higher amount. And so we have a lot of data-driven strategy that we employ around those rewards. So we make sure that we're spending those dollars effectively. We also consider, of course, budget, but the ability to impact a measure. You know, in AlohaCare's case, where we're setting those specific goals on a healthcare activity, we know that, you know, on those that we think we can improve within the measure year, we might set a higher reward value to make sure it performs. We also have to consider the barrier of the activity. There are different barriers. A flu shot is not the same barrier as a diabetes eye exam, and the reward amount needs to reflect that. And then a final thing that I would note in all the data that we have is the total reward amount also matters. Members may not complete all the activities that you're asking them to do, but members that have more money to earn in total in the program have a higher engagement rates. So we find higher performance, for instance, on diabetic eye. Instead of marketing the diabetic eye in isolation just for $25, we find higher performance when we pair it with an annual wellness visit for $25 and a flu shot for $15 and actually create a total reward value that's higher. We see better gap closure and get some great performance on additional activities as well. Another key strategy is motivating members to engage is the content. AlohaCare has many high-need populations, and to effectively engage them, we really need to build trust for individuals, and that really starts by personalizing the messaging and member experience. In the AlohaCare program, we aren't reaching out to members with a laundry list of the healthcare activities in the program. we're engaging members with specific healthcare activities for them and their child, and we have to prioritize them in order that's most important for the member to complete. So with content, we're trying to turn confusion into confidence, frustration into security, and we're trying to also get members to feel cared for and supported by the plan. All the activities are written to 6th grade reading level or below, and we want to help members kind of plan their healthcare activities, remember what they need to do, and really empower conversations with their provider. To do this, all the messages are really targeted and centralized around overcoming barriers and addressing them head on. For instance, cost could be top of mind for a member, so I'll just read a quick excerpt from the IVR content in AlohaCare's program. It's, once you complete an activity on your prenatal or postpartum care checklist, let us know and we'll send you a reward. It's that simple. There's no catch or cost, just rewards for taking care of your prenatal health. Another key best performance practice that we have is for all the healthcare activities we're driving, we have an overview of the ask, and we also have content on what the member can expect. We want to make sure that we support health literacy also around multi-step activities. So we also do provide educational content. An example is here on the left. It's a well child insert that helps a family understand how many visits they need to do, what happens at each visit, what screenings are included, what's the immunization schedule, and when visits should occur for their baby. And then finally, as I mentioned, a sustained communication plan is really important, and multi-channel is imperative. Just like gift cards, a key to personalization is providing choice, and that means communication channels as well. We have to meet members where they are. So personalization really does go beyond a mail merge. We have some members that prefer mail. We have some members that prefer digital and phone. And the key is you can't just do one thing and expect optimal results. What we find is a mail campaign that's supported by IVR, supported by email, delivers a really significant lift in engagement. And the engagement shouldn't stop when members sign up and start to engage in a program. You have to thank them, recognize they're participating, and continue to engage and remind them of what they need to do until they've really closed the gaps that they need to close. And in the AlohaCare program, we're engaging members by IVR phone calls, live call center. We have outbound mail that includes postage paid envelopes so members can report their healthcare activities and select their gift card by mail if they choose. We have a digital online platform that's mobile friendly. And not only do members have their choice of gift card, but they can choose a digital gift card or a plastic gift card to be received by mail. AlohaCare members today are using all of these channels. They're using all these gift cards, which is a real testament to that choice is important. We do ask members about their channel preference, which is important. But in the event that they don't select the preference, tracking and measuring and following members in the channel they engage in is really important. If we have a member that's engaging online, they're responsive to emails, that's how we want to continue to follow them through their journey and honor their preference. Multi-channel also provides flexibility in communicating with members whose language choice is not English. So in the AlohaCare program, we have Google Translate that translates digitally. We have a language line within our live call center that supports up to 200 languages. And then in AlohaCare's mailings, they're also providing a 17 language disclaimer that's directing members to the language line for the language that they speak. And then lastly, unlike some standard marketing activities where you're measuring web clicks and email open rates, we're closing meaningful gaps. That's what we're measuring. And member engagement programs, we believe, should be measurable and be able to be tracked and demonstrate an ROI. We monitor client programs daily, and we do that so we can adjust them in real time. Which members are getting more or less outreach, what channels are performing the best, and do we want to optimize more? Which measures are the plans doing well and which aren't? Do we need to step on the gas? Continually measuring the programs allows us to make the real-time decisions and make sure that we're going to meet AlohaCare's goals. And then finally, putting all these strategies together is key. Member engagement is a discipline. It's a process, it's hard, it's time consuming, and it does take a lot of resources that some plans don't have. But building member engagement and having this discipline is really important to support your hardest to reach members to make sure that they get the care that they need. All of these strategies kind of employed in isolation, we don't find them to work. Personalization, which out giving members choice, isn't personalization. Executing communication plans, but just sending one mailing that's not follow-up really won't drive the performance needed to drive behavior change. So this performance is a framework that's truly more than the sum of its parts. And you do have to personalize, you do have to segment the population and strategically use rewards and incentives, integrate messaging resources and to overcome barriers, offer choice, deliver consistent, relevant multi-channel engagement, and then continue to measure and refine and adjust along the way. And I won't spend a ton of time here, but we have, as I mentioned, some early data from AlohaCare. It's what we would expect to see. Here are some data-driven insights that we have learned that do hold true universally plan by plan and region by region. So you can kind of hopefully jumpstart and skip some of this testing phase. A couple key insights here, a few that I'll call out is annual wellness visit is a key driver. We find even when we're trying to improve HEDIS quality, when we add an annual wellness visit, getting members to engage with their provider, we close 3 times the gaps. And we see that consistently in all the programs that we run. Also, when we get members to come into these programs, engage, earn a reward, and close a gap in care, we do see a retention improvement of about 15%. Engaging new moms in prenatal activities, we see if we can engage moms in prenatal, she's over 2 times more likely to go on to complete those well child visits. And so we see some good trends. We're going to continue to monitor performance data and evolve. Currently for AlohaCare, we're focused on those non-compliant gap closures. We're testing the ability to drive behavior within the hardest to reach within the population. In the future, we're going to be measuring the impact on retention, potentially layering in additional objectives. And some of the key learnings from this program we have this year with AlohaCare are really going to help inform some of the engagement strategies that might be needed once the coronavirus vaccine is available in 2021. So there's a lot of exciting data and learnings that will be actionable for AlohaCare as a result of this program. And on that note, I hope that you found this to be informative and more importantly, actionable. And I will stop there and we'll turn it over for questions.
Okay, our first question today. What's the cadence of the personal outreach? For example, text, phone, are they being sent on the same day or a day apart?
That's a really good question. It depends on the program and the member. So each member really does get a personalized journey. We typically start in digital channels to see how much digital engagement we get, because that can be helpful for performance. And then from there, if we're not getting that performance, we're switching to other channels like mail, like phone, but we're kind of staggering and doing some mini measurements. Obviously, digital and that IVR phone call, we're going to get more data in real time faster. Mail takes some more time to measure that full performance.
Our next question, please address how ROI is measured, including how it's determined that Novu's intervention are the cause of better engagement and not another factor.
Well, I can take that, Jihan, if you'd like. So I think one of the things that I've really appreciated about the partnership with Novu is that, as I kind of alluded to earlier, we didn't have the resources to quickly ramp something up here. And so this came to me as kind of like a full service option, right? Like we'll take the data, and that's like our big lift is getting the data to them. And then they take that data, they process the data based on our needs, they send out these mailers, they process the attestations, they send out the gift cards, and then they send us back these really beautiful reports. So we know who attested, We know how many people attested. We know that as a percentage of, our total eligible population. We can see if there's a preference, and this is like sort of a side effect, a good one. We can see what people's communication preferences are. If we have a bad phone number, but they are able to get a good phone number by reaching somebody by mail, we get that information back. But ultimately, I have all this information coming back to me, and I can take a look at that information and see those numbers going up. And for me, a subset of those, most of those that we had selected as target areas or measures are areas where we have a withhold from the state. So the clearest ROI, the quickest ROI is if I have $5 million a year, and I'm just making up numbers here, but withheld from the state based on these quality measures, I can just mathematically tell you on a person-to-person basis what every eligible individual gap closure is worth. And it's worth more than what we're paying out in incentives. So, and that's just from that one piece. So then you layer on top of it the potential cost savings down the road by keeping somebody healthy. And that just kind of compounds to me, right? And the member satisfaction on the CAP survey, and that just compounds. So I see a really clear short-term ROI, which is helpful for me to be able to sell that to my peers on the executive team. But there are a lot of there's a lot of ROI there, I think. And then the other thing that I'll just share with you is we do connect this back into our own system so that we can see what portion of that that gap closure is driven by this as opposed to something else. Although I will say, if you consider how these folks are targeted, right, the fact that they are historically non-compliant, they were the least likely to just go ahead and do it on their own. So the likelihood that this incentive was the thing that drove them to make that decision is pretty high. It's possible that somebody with really, well-documented historical noncompliance would just spontaneously decide to get a PAP, but it's kind of unlikely. So it's a fair assumption that this is driving that improvement.
I would also just note too, because the member is coming back and attesting, and they're engaging with the program. Yes, they could have seen it somewhere else or made that decision on their own, but the program did play somewhere in there in that measurement. It's a tricky one because in quality gap closure, you want to close as many gaps as possible with those historically non-compliant people. But one, thing to do to help measure attribution when you're doing something like this is to carve out a small control group of the non-compliant. So you can kind of truly measure, what programs are driving efficacy and really what aren't.
Okay, our next question. Are providers incentivized on any measures outside of just the state-focused HEDIS measures? And have you thought about incorporating outcomes-based measures such as preventable events?
Yes. Yeah. So, that's, I guess, I could probably do like a whole separate session on that because that's one of the biggest, I think it's probably one of the biggest uses of my time is working with providers. And we have a number of ways that we do that. We do have sort of a standard P4P program where we do incentivize providers. We incentivize our health centers differently because they essentially are our plan, right? Like they are the leadership of our plan. They're the most important part of our plan. And we have special program by which they can earn back money that is driven by measures. Yes, the withhold measures, also non-withhold measures. And we are, for some organizations, starting to trickle in additional kind of hospital, type of measures of readmission and preventable and stuff like that. But I think most unique thing about AlohaCare is that because of that relationship with the CHCs, we have a long documented history of having some kind of risk sharing agreement with our health centers. And more, those things are being tied together, the sort of cost management and the quality piece. Also, one of the things that I think we do really well is just the data integration. So we have a great deal of data integration with our health centers, and we've actually supported a lot of the development of that. So they appreciate that, and we obviously do too, because it helps us manage our quality. So I hope that kind of answers the question at a high level. There's a longer, complicated answer, but yes, we do.
Okay, next question. Did you state it's best to focus on the non-compliant members versus compliant? And if so, why?
Do you want to take that one, Amy, or do you want me to?
You can actually.
Okay. You know, there can be value to both, but when budgets are really limited and you're looking for incremental improvement, rewarding members who are already compliant, who already see that intrinsic value for getting their breast screen or cervical screen or bringing their child in and having that provider relationship aren't really where you need to focus those budget dollars. It's really on those people that have barriers, they're not engaging, maybe they don't know how to engage, but they don't have that provider relationship. That's where you see that ROI, right? And that behavior change and that incremental lift. And so we highly recommend, when dollars are limited, to show quality improvement, to really focus on those historically non-compliant members to give them that extra support.
Yeah, and I would just share that I think, we had made a business decision at the outset of the partnership that we were going to allow for payments if somebody found out about this program. So we are targeting individuals. We are heavily marketing this program to individuals who have historical noncompliance, right? But it's possible that a family member has been compliant or their best friend has been compliant, and they, find out about it, and they, call and say, hey, I heard about this program. Can I get this? I did this earlier this year. Yes, you can. Like, we're not trying to make anybody upset or get anybody angry. If somebody finds out about it and they think it, they would like it, great. That's fine. It's really not a big secret. People do kind of know about it. We've actually, just as an aside, we've had some of our providers say, hey, do you want us to tell people about this? And we said, no, not really. Just let it happen. And I think it's one of those things we'll learn from. And if we feel like we need to expand the population or change like the targeted population so that we're going beyond just the historically non-compliant, we will do that. And an example of that is, our prenatal and postpartum. For obvious reasons, we didn't pick people that were historically non-compliant. They're all in the pool because presumably they weren't pregnant last year and the year before. So you don't have that track record. But we've been considering the possibility of doing something similar with childhood immunization, just because it's such a big deal. Maybe we just want to open it up and, ensure that not only are we targeting historically non-compliant, but we're targeting people, kids who are historically compliant, but who may be less likely to be compliant this year or next year because of COVID or whatever else is going on in the world. And I think the fact that all of that is flexible and that we can change the way that we approach this at any time it's really been reassuring to me, because we do like to be able to pivot quickly.
That's a great point. And the strategy can change within the year, or it can change from year to year or measure to measure in how you target.
Okay, next question. Legally, can you take phone numbers gathered in the Novu campaign for internal health plan use?
That's a good question. I'll let Amy answer that. I will say that our system captures preferences and that data, and then we provide it at a regular cadence back to the plan, but the plan's the source of truth. So we kind of wait to see, is the plan going to take that data and provide it back to us for us to outreach to the member that way?
Yeah, so we can take that information back. In fact, we also have an imperative to share that back with Medicaid. So that's kind of been a historical issue here. We've had a lot of issues with contacting people, and the state has as well. And so that is something that I think of as kind of a positive side effect of this program.
Okay, our next question. I'm located in Los Angeles County, and a big challenge that we have is the digital divide. Many of our members do not have Wi-Fi or equipment. How do you address this?
So one of the options, as Jihan mentioned, is that we send mail. We actually, even though we do have fairly good coverage, there are definitely some islands and some pockets where we do not. And there are a lot of older people on our plan that are just not set up. A lot of houseless individuals that, do have a mailing address, but they do not have internet access. And so, yeah, we do both. We have send the mailers. The mailers have been very popular. It's the omni-channel approach, I think, is really helpful. It's, you're hitting people multiple ways, and then they can say, hey, we don't want any more mail, right? And they'll stop mailing. Or, hey, we don't want any more text, and they'll stop texting. But we love the mail, they'll keep mailing, right? So we do have that flexibility to send information different ways, as well as, I think somebody asked this in the chat, but the gift cards can be physical gift cards or they can be e-gift cards. So if people are tech savvy, they can go online, they can do the attestation, and basically it's like that, right? It's just immediate, like I get a gift code, I can go directly onto Amazon and buy new baby bottles, kids underwear, like school supplies, right? Whatever I want. If I don't really know what to do with a gift code like that, because I'm an older person and I'm living in Oahu and I would like a physical Walmart gift card, I can get a physical Walmart gift card and go to Walmart and do my shopping. So I think it's really nice for different ages, really nice, as Jihan mentioned, for different locations, because there are several locations like Lanai and Molokai and parts of Big Island that do not have these different shopping options. And for several of them, there is not any of those things. There are none of those retailers. There's no Walmart. There is just the possibility of Amazon, and that even takes a while, but that it really makes them appreciate it that much more that they have that, because I think people feel seen by that, and they, it meets a need. Like I know we had a lot of options, but we purposely chose things that we knew our membership would use for, family needs, for groceries and prescriptions or whatever, right? Like non-prescription medication. And that's kind of the feedback that we've gotten is like, oh, we bought the kids like back to school clothes, or we bought, school supplies, we bought food. And that's kind of what we had hoped for. So it worked out really nice.
Okay, I think we have a quick question. Is Novu based on the mainland, and does this affect your members' timing of phone calls, language barriers, and lack of local touch?
Yes, this is a good question. So they are located on the mainland. I will say, I mean, it's extremely unusual to work with a vendor that's located here. There aren't really any. So that's kind of, it just takes away that option, right? I think we're a very local plan. We probably would work with a local organization if there were, but we don't have that option. So, we found NovuHealth, and believe me when I tell you, my team, the first thing that they're going to ask you is that laundry list of questions. Like, what are your translation languages? Are you willing to rewrite, the website, the material, etc., to use our parlance, like the way that we speak to our members? It's really important that you say aloha and not hello when you answer the phone. This should come from an 808 number. People aren't going to answer the phone because we have one area code in the whole state. And so everybody knows if it's not an 808 number, it's spam, right? So we address all those things right up front. And I think on, the spectrum of how responsive an organization has been to our unique needs, I think that they've been way more towards like the side of, like we can just be flexible, we can figure that out. And we really appreciate that because it is unique. We know it's unique. We're not a huge market. So we know that when you develop something or design something that's for us, it's not like you can use it, in a lot of other places. You can't market your Aloha materials in Arizona and, Nevada. You could, but it'd be sort of weird. So we really do appreciate that they've been thoughtful about what's culturally unique. And it's been well received. And in terms of the hours, same type of thing. Like they knew right up front, we have different hours. They're significantly different, right? Like we're six hours behind the East Coast during daylight savings, and then 5 hours the rest of the year. So it makes a big difference, and they've been great about that as well. We've had no complaints at all.
Okay, well, we've hit our allotted time. We do have a couple extra questions that we will give to the panelists, and they can follow up with those that ask those. With that in mind, I'd like to thank Amy and Jihan for a very informative webinar today. And I'd like to thank all the attendees for taking time out of their day to join us. With that in mind, thank you and stay safe.
Aloha.